At the outset, thank all the chairpersons and panelists for having me here and care group as well. One-stop refractive solution, and that is absolutely right as far as phakic IOL is now concerned, especially with the advent of presbyopic phakic IOL as well. Really, there's really no power and no eye that you cannot treat with phakic IOL. And it's a matter of great pride for me. And I say this not just because this is a care group session, but really they have taken the step forward with the IPCL in terms of giving us the level of comfort, customization, accuracy, repeatability that with a lot of pride, I'm able to tell my every single patient that there is absolutely no difference. There is no difference when it comes to an ICL or an IPCL. But there are actually differences. And let me tell you that there are differences which works in the favor of IPCL. And I'm not just trying to highlight those, but these are actual genuine points that make a difference in our day-to-day clinical decision making. Diopter range, there is almost, like I said, there's no range of hyperopia or no range of myopia, no range of astigmatism, which is not possible, which we cannot correct with the IPCL. Customized lenses are available for all range of powers. Material hardly makes a difference. The hydrophilic acrylic of IPCL is extremely good in terms of biocompatibility. You do get cases of pigment dispersion, but the thing is, we remember those cases which have only those pigment dispersion. And that happens with both cases. I've had Tourette-Zavalia syndrome with ICL also, and I've had patients with pigment dispersion with IPCL also. These are because these are young, high myopes, which are prone for pigment dispersion, and that's why we end up talking a lot more about the material. The holes, now the central flow is very much available in the IPCL also. The central hole is available. The size is quite similar, just a few micron difference. I'll show you in the next slide. Apart from that, for draining the visco, it has additional holes near the foot plates, and the foot plates themselves, the pads themselves have large holes. So any peripheral viscoelastic can also be removed very easily. So no PI is required, and definitely the fear of anterior subcapsular cataract also goes out of the window. One of the biggest advantages is that there is no parallax error. Every IOL is customized. You can implant it in 0-180. It's really a pleasure because you just put the IOL inside, keep it in place, and the surgery is over. No rotation, nothing is required. And especially if you don't have access to a, let's say like a Varion or a Callisto, manual marking, and this thing definitely brings a certain degree of error into this overall calculation in these high-powered patients. And there's the hole size, like I said, is almost very similar. The slight difference is, this is actually a picture of this older version. The IPCL has a knob on the leading left and on the trailing right, because these are the most important ones. Although you have these two holes which are superior, but you can still have them the lens completely flipped and still have the two holes superior. So just don't go by those two superior holes, but that knob on the leading left and on the trailing right, I'll show in a video subsequently, will be the main indicators. Again, optic size, you get the larger diameter optic size, which are again customizable also, so that in patients with larger mesopic and photopic pupils, scotopic pupils, you can go in for customization, and that's one of the biggest advantages. Also, the lens itself has a beautiful mid-peripheral rise, which even in patients with low vault, the IOL is actually a little above the lens, let's say in patients. Now, still today, the measurements which we do for phakic IOL are not very accurate, whether it's the white to white or the lens rise. There are repeatability issues, there are challenges, and we have to admit that. So when our measurements are not accurate, it's good to have a lens which is forgiving. This mid-peripheral rise allows that even when the lens is slightly undersized, still the vault is maintained, and these patients have no issues with regards to cataract whatsoever. There are 6 haptic pads, which ensures better stability in the ciliary sulcus, and of course large holes in the haptics, so that even if the lens is slightly oversized, it's quite flexible and rests down beautifully. So this is just to show you the identification marks. As you can see here, the knob on the left, sorry, the video is not running. Anyway, then there's a knob on the leading left and the knob on the trailing right, which is what you need to look out for when the lens is opening. And you can gently twist it around. It's an extremely pliable lens and can be inserted as well as removed through the 2.2, 2.8 millimeter lens, whichever you want to use. Oh, finally it's working. So just a close-up of the lens itself, and you can see the superior holes and the knob on the leading left. Loading again is very, very easy. There's no special training required. ICL, you still need a few cases before you get used to the loading. But IPCL is simple butterfly cartridge. Just use saline BSS and load the lenses. It's extremely easy to load. Just press it down. Very, very hard to make a mistake as far as the loading of these lenses are concerned, and you get excellent outcome with these lenses as well. So the sizing, like I mentioned, is a challenge, and white to white does not correspond to sulcus in all patients, and there are patients where you can go wrong, and there are high myopes where assessing the exact white to white itself becomes a challenge. The discrepancy between the white to white and the sulcus to sulcus can be more. Although you have UBM, ultra high frequency UBM, certain high frequency ASOCTs which are now available to measure these, there is still a significant variability, inter-observer variations which are there. So when the measurements which we are providing are slightly less than accurate, it's important to have the option or the flexibility in terms of your sizing. Because you have a wide variety of lenses available in just 0.25 millimeter steps, you can so easily choose the lens according to your need. And if at all you do land up with a small problem like these patients with a low vault, though however these are two patients, two eyes of the same patient with 130 micron in one eye and 85 microns in the other eye. And after 6 years, this photograph, the patient continues to, the lens remains crystalline, lens is absolutely clear. So really, there is no need to rush in and exchange the lens at any point of time. And if I were to err on the side of caution, I would rather have a lower vault than a high vault with these centraflow lenses. Because occasionally, what gives the trouble is the high vault. Because especially in keratoconic eyes, where you tend to overestimate the anterior chamber depth, you could have a high vault where the iris tends to slide under the lens, and you may have a little capture of the optic, and that produces a little more photic phenomena. And the other thing is, of course, you need to keep them on follow-up with high vault and look for any goniosynicae which are developing. If it is developing, please go ahead and exchange with the lens of a smaller size, and they'll do extremely well. Again, you have various instruments to measure. One thing I would say is try to corroborate your values with your digital caliper with at least a couple of other devices, the topolizer or the topographer, whichever ones you're using, and ensure it is there. So it's just a exchange for a high vault. I mean, I'm not going to, for paucity of time, won't go into the details. But suffice to say, it comes out so easily through the same incision, and you can use the same incision to do it. Or even if you have a cataract, it becomes extremely easy to go ahead and do it. These are just a couple of early papers. This is almost now 5-6 years old when we did the initial study on the IPCL lenses and found it to be an excellent in terms of safety, efficacy. And also we did an initial comparison of IPCL and ICL and found that they were equally effective. The incidence of long-term outcomes, complications were all very similar between both the groups. Quick couple of words about the presbyopic IPCL, which is a trifocal diffractive design, and it has varying powers which are available, 5 variants which are available based on which you have the near and intermediate add. So you can mix and match based on the age of the patient, whether they're a young presbyope like 40, 41 or whether they're older presbyope like 50. So based on the requirements, you can put one IOL in the non-dominant eye, the other in the dominant eye, and give them a beautiful range of vision. And because the rings are lesser and the lens is closer to the iris, the amount of photic phenomena that these patients have is also very, very minimal. I am yet to come across a presbyopic IPCL patient who is bothered by the photic phenomenon. So much so that multifocal patients, I definitely talk to them, multifocal IOL patients, I talk to them about photic phenomena. It's important that we educate them. But presbyopic IPCL patients really don't have as much difficulty, primarily because of the anatomic location. Quick word on keratoconus. Again, keratoconus also is a beautiful device to use in patients with either high anisometropia or even bilaterally if the patient has excellent best spectacle corrected visual acuity. Acceptable, that is 6/9 or better. Good spectacle corrected visual acuity are patients and stabilized keratoconus. This is just a follow-up of 126 eyes, and some of them require topo-guided PRK or Intacs earlier to begin with, stabilize the cone along with CXL and improve the overall quality of vision. Best spectacle corrected visual acuity of say 6/12 or better, at least 6/9. Then these patients do extremely well. I'll just quickly run through the outcomes. Very good. This is something I want to highlight. When the anisometropia is corrected, 40% of patients gained one or more lines. Now, this is unmatched. I mean, you cannot have any refractive procedure which gives you a gain in BCVA of 40%. And because of the high degree of ametropia and anisometropia, which is very common in keratoconus patients, they have excellent outcomes. We looked at low astigmatism and high astigmatism. Even customized lenses, 8-9 diopter lenses also did extremely well. The outcomes between low and high were very similar. Differences between ICL and IPCL was also very, very similar. The outcomes were absolutely the same. Centered and decentered cone. Previously, we used to think that decentered cone, stay off phakic IOL. Again, it's not a 100% hard and fast rule. You will have patients with a cone which is slightly decentered on the posterior float, but they have excellent best spectacle corrected visual acuity. If they have good best spectacle corrected visual acuity, they do extremely well and the outcomes are just similar. So with appropriate case selection and satisfied BSCVA and appropriate sizing, you can have excellent results even in these kind of situations. Thank you so much for your kind attention.
That was really wonderful.
Sure.
I agree entirely with you. IPCL really works extremely well, and the results long term seem to work out extremely well also.
Sure. I just like to. I think beautiful presentation, Shreyas. I couldn't agree more with you. I probably have the largest series of IPCL in the world, more than 3,000 phakic lenses implanted. Few words of caution: don't always target 1.25. If you have a large pupil, a 1 millimeter large is good enough. Because since these lenses are customized, and if you go in for a larger pupil size lens, then 1.25 is going to give you a lot of pigment release. So a few pearls from my experience: keratoconus patients, plan a slightly lower volt.
Smaller lens.
Do a PI in these patients. Any astigmatism where the vertical axis is steeper, at least do a vertical measurement and also do a PI, because the chances of you having, even if you planned the angle well, the vault well, can go wrong. So I've had patients where, 11 diopters of astigmatism. Sanjay is here. He's made 14 diopters of astigmatism for me. And I couldn't agree more with you, These patients do exceptionally well. 14 diopters of astigmatism, corneal scar, perforation repaired, peripheral perforation in childhood. Patients, we were given up for amblyopia, and suddenly they are seeing 6/12. So amazing results. And one more advantage of the extra hole is the way you can remove this lens by just enclavating a blunt instrument. On the YouTube, I've described it as a hook technique. Just go in, hook the instrument and pull it out. It just comes out in one go. You don't even need to. Whereas in an ICL, at times you pull, it tends to break. This lens will never break. It can stretch like a rubber band till approximately 20 millimeter. I've stretched it till 20 millimeter, it doesn't break.
And just a quick addition on the keratoconus. Oh, sorry, sir.
No, sorry.
Keratoconus, where you have patients with a slightly higher Kmax 60, 65, the ACD will be falsely high, our measurement. So it is, like sir said, it is important to err on the side of having a slightly smaller lens rather than having the same size lens what you would have for a normal patient who's non-keratoconic. And then you will definitely have lower, more appropriate vaults.
And do a PI in these cases.
What is the cutoff for both of you for difference between a star ICL and an IPCL as far as the ACD is concerned?
See, again, Kumar, this is tricky, but they say 2.8, but off the label, I'm not supposed to say it. I've gone much lower than that. I've also done it in hyperopes. 12 hyperopes, 3 I had to explant, but I told the patient, I might be needing to explant. To 2.64 millimeter also I've done and got away with it. But it's the profiling of the lens. It is not exactly the AC depth also. In a hyperope, it's the profiling of the lens. which comes into play. So, and the cataract, I've had 4 patients whom I'm observing. You see, another good part about this lens is the resting vault is 440/500, which is amazing. You leave an ICL, it'll fall flat. You leave this lens, the meniscus of the curvature resting is 440/500. Correct me if I'm wrong,
The
Sanjay.
mid-peripheral rise
So
is very
it will
useful.
always have a rise until and unless your lens rise is more than 600 millimeter, 600 microns. So if your lens rise is higher, that could be the only water you have. Otherwise, this lens is not going to touch the posterior capsule, because even on the resting plate, it is 440.
So what's your cutoff or ACD?
I take 2.8 for my standard patients. ACD 2.8 millimeter.
So to answer your question, myopic patients, I don't hesitate in going lower, 2.7 or lesser. In hyperopic patients, like Sir mentioned, because of the profiling of the lens, I tend to stick to 2.8 for hyperopic patients. But myopic, I'm quite comfortable going lower. We've done quite a few cases, and they are doing extremely well, sir. And like I said, because the lens is available in 0.25 millimeter sizes, you can slightly undersize the lens and for that lower vault and do extremely well.
To answer your question specifically, Kumar, if you going in for a larger optic size, you can play with a lower ACD. But if you have a smaller optic size, that's when the low ACD will start playing out. So if I'm going for a 7 millimeter, 7.25, they manufactured 8.6 for me also. So there it doesn't matter, because the resting force of the lens itself maintains a vault. So 6.2 to 6.5, you can have a cutoff of 2.7, 2.8. But in case you're going for a larger optic size, you can play with a lower vault also.
Actually, when the ACD is around 2.6 also, they customize the lens in the appropriate manner to give the correct vaulting. One thing I want to add, just for initial surgeons, don't suddenly push the IPCL or Refractive suddenly. Just go 50%, let the lens unfold, see your holes and knob, then again 25%, then see everything is right and pushed. In my cases, I'm doing for more than 8 years, 9 years now. I've not found any single case opening in inverse manner. So design-wise, initially I started when I was in Chennai, I started ICL, and then I shifted to IPCL. I'm telling you with my experience, design-wise, this lens is much superior than ICL.